Assalamualaikum warahmatullahi.
Waalaikumsalam, Doctor.
I think we can start our session.
Can you guys hear me?
Yes, I can hear you.
Yeah, thank you. So, Assalamualaikum warahmatullahi wabarakatuh, and a very good evening. My name is Muhammad Daniel Afif bin Muhammad Nazri with the metric number of 16035. I will be presenting about the Hinox calling purpura, or the short name is HSP. So, this is my outline. I will be talking about the overview, clinical features, investigation, complication, management, and also the resources if you guys want to see it. Okay, so the first thing I will talk about is the overview of this disease. So HSP is a disease involving inflammation of a small blood vessels. It is mostly occurs in children, but it also can occur among adults. The inflammation causes blood vessels in the skin, intestine, kidneys, and also in joints. So the main symptom is a rash with numerous small bruises, which have a raised appearance over the leg up until to the buttocks. So although HSP can affect people at any age, most cases occur in the children between the ages of 2 until 11 years old. And it is more common in boys than girls, and also white or Asian men are more prone to anyone else in this world. And then adults with HSP are more likely to have more severe disease compared to the children, when HSP usually ends after 4 to 6 weeks. So it doesn't really proceed to a chronic disease unless, but still there is a chronic disease of HSP, but it's very rare. And then sometimes with recurrence of symptoms over this period, meaning that in these 2 to 6 weeks periods of time, the patient can come up with the same symptoms all and over again. It is a normal if recurrence occur. And then if organs such as kidneys and intestine are affected, treatment is often needed, and it's important to have a regular follow-up to prevent more serious complication. And the exact cause of HSP is not really known, because the body's immune system is believed to play an important role in targeting the blood vessels involved. An abnormal immune response to an infection may be a factor in many cases of this disease. Approximately 2/3 of the cases of HSP occur days after symptoms of an URTI develop. So, some of the cases of HSP, it have been linked to vaccination for typhoid, cholera, yellow fever, measles, or Hep B. So the classic clinical tetrad, usually patient came out with the rashes, abdominal pain, hematuria, and also arthritis. Next, we will be talking about the clinical features of this disease. So the classic symptoms of HSP are rash, joint pain, swelling, abdominal pain, and also the kidney-related disease. Before the symptoms begin, patient may have 2 or 3 weeks of fever, headache, and muscular ache. And it really affects the organs, such as brain, lungs, and also spinal cord, but it can be affected. So the first one is the purpura. Most patients, there is the 100% chance of patient can develop the purpura, which is the skin lesion. So the rash usually appears in all patients with HSP. The initial appearance may resemble hive with small red spots or bumps in the lower legs, buttocks, knees, and also elbows. But these change to appear more like bruises. The rash usually it affects both sides of the body equally, and when we press on the bruise, it doesn't turn pale. This is also one of the main important points. And next is the joint pain. Patient can also come up with the arthritis and also arthralgia. It is a joint inflammation involving pain and swelling occurs approximately in two-thirds of the cases, particularly affecting knees and ankles. It usually affect the lower organ, lower joints in our body, in the patient body. And it usually lasts only a few days and does not really cause any long-term or chronic joint problems. And next is the abdominal pain, which occur in 50% of the patient, among the patient. So in more than half of people with HSP, inflammation of the GIT may cause pain or cramping. It may also lead to a loss of appetite, vomiting, diarrhea, and also occasionally blood in the stool. So the patient can also come up with the melena and hematochezia. In some cases, patient may have abdominal pain before the rash appears. In rare cases, an abnormal folding of bowel, which we call as intersusception, may also occur, and it lead to a bowel blockage, which we need a surgery to treat it. And next, the less important clinical features is the kidney impairment, which is quite rare. But HSP, as we know, it can cause the kidney problems, indicated by such signs as a protein or blood in the urine. This is usually only discovered by urine testing, since it does not generally cause any discomfort in our patient. And in most patients, the kidney impairment is mild and it goes away without any long-term damage. And it is also very important to monitor the kidney problems closely and make sure they clear up. Since about 5% of the patient, they can actually develop progressive kidney disease, and about 1% out of all patients, they can develop a total kidney failure. So we also need to take a serious uh, on in this. And next, I'll be talking about the investigation of this disease. So, generally, the routine laboratory test results are within the normal range, but it can also increase or decrease, depends on the what type of test we did. So the first one is FBC. We can find the normochromic normocytic anemia due to the occurred GI bleeding, and also leukocytosis due to bacterial infections, and also the platelet uh, platelet is normal. For the platelet count and coagulation studies, platelet count is usually in the normal range, but it can be elevated. In HSP disease, platelet count it cannot be less than what it is, because a normal platelet count rules out the ITP, and a normal platelet count with a normal coagulation studies, it rules out the TTP. And next is the urinalysis. In the urinalysis, we may found hematuria and proteinuria. It is usually in 10 to 20% of our patients, so it is not that many. And next is ESR and CRP is increased due to the inflammation in the organ. And next is renal profile, which is BUN and creatinine levels. It is maybe elevated from renal involvement of HSP, or it can also be due to dehydration. Next is IgA level. It may be elevated. It is elevated in 50% of the cases. And next is lipase level. We need to do a lipase test because a normal lipase level makes acute pancreatitis very unlikely in our patient. And last we're talking about this abdominal ultrasound. It is used to diagnose intersusception. Okay. Next, I'll be talking about the complication of HSP. Since GIT and GIT, renal and joint are the organ that are most likely to be affected, so we need to take a serious, we need to take into account lah. So the first one is GIT. It can lead to a temporary abnormal peristalsis, and also I'll be talking about it. It can also cause an intersusception, and it cause complete obstruction or infection with a bowel perforation. For the renal, it is rarely developed in a failure, but it also can cause deteriorating renal function and nephrotic syndrome. For joints, even though it can cause periarticular edema, it does not really leave any permanent damage to the joints. So, as mentioned, HSP is a self-limiting condition which usually gets better by itself. The majority of children recover without any long-term side effects. So generally, most children would recover within the 2 to 4 weeks of duration. But however, HSP can be prolonged in some cases, and there are children who do get recurrent HSP episodes. And next, I'll be talking about the management of HSP. As of 2017, the optimal way to treat HSP remains controversial. It is because we don't really know if steroids does give a benefit to the HSP patient or not. So what we want to give is analgesic. It may be needed for the abdominal and joint pains. Wound care is also warranted if the skin death and ulceration occurs, especially at the lips. And it is uncertain as to whether HSP patient needs treatment beyond controlling their symptoms, because what we want is to treat the symptoms first. And most people do not really receive therapy because of the high spontaneous recovery rate that I've mentioned. And also, experts also disagree on whether to routinely use corticosteroid as treatment for HSP. However, we can give the steroid as it will reduce the duration of symptoms, and also abdominal pain can improve significantly. Moreover, the chance of severe kidney problems may be reduced. A systemic review did not find any evidence that steroids will actually effective at decreasing the likelihood of developing long-term kidney disease. So to conclude the management is that firstly, we need to give a supportive treatment, which is analgesia, bed rest, and also maintain a good hydration of the patient. But if it proceeds to the GI pain or renal involvement, we can give them steroids. Okay. And this is my reference. I use the UM to treat the most. That's all from me. Thank you.
Okay, we continue with the next relation. I think we leave the question to the end.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I am Wanu Shazwani binti Wan Yusof with metric number 1816982. Today we'll be presenting the topic of Kawasaki disease. So what is Kawasaki disease? So Kawasaki disease, which is also known as the mucocutaneous lymph node syndrome and Kawasaki syndrome, is an acute febrile illness of the early childhood, which is characterized by vasculitis or inflammation of the vessels. Particularly, it involves the medium-sized arteries, most pronounced in the coronary vessels. However, Kawasaki disease may also occur in veins, capillaries, small arterioles, and larger arteries. So Kawasaki disease was first described in Japan by Tomisaku Kawasaki in 1967, and it is most frequently observed in Japan, Taiwan, and Korea. Kawasaki disease becomes one of the leading cause of acquired heart disease in infants and children, and it mainly affects the children less than 5 years old, with a peak at the end of the first year. And the patterns usually show that it is slightly common in boy than girl. Okay, so next, what causes the disease to occur? So ultimately, it is unknown why this happened. So some theories suggest that the Kawasaki disease, it has some infectious origin. However, the researchers are not yet able to come up with a single etiology agent, though autoimmune reactions and genetic predisposition probably play part as well in this disease. Next, we go into the pathogenesis of the disease. So whatever the case is, when the endothelial cells are attacked by the immune system, they will become damaged, which expose the underlying collagen and tissue factors from the middle layer of the blood vessels, and this may lead to a few serious problems. So first, these exposed materials, the collagen and tissue factors, will increase the chance of the blood coagulation. So when the blood coagulates, it will lead to the blood clot formation. And when there is the formation of blood clot, they may lead to the blockage of the coronary artery, particularly, and may cause ischemia of the heart muscles. Secondly, damaged endothelial cells in the coronary arteries means weak artery wall. So when this happens, it may lead to coronary aneurysm, in which this happens because when there is so when the damaged endothelial cells happen, the fibrin acts as the as part of the process is deposited onto the coronary vessels. It makes the endothelial cells to become the vessel to become more stiffer and less elastic, and it can gently stretch whenever there is high arterial pressure. Instead, it bulges outside, causing the aneurysm. Thirdly, the fibrin may also cause the blood vessels to become thickened, and this may restrict the the lumen of the vessels and restrict the blood flow. Subsequently, may cause also ischemia of the heart, and lastly, may cause the myocardial infarction. Next, we go into the clinical features of Kawasaki disease. So here are the 5 principal clinical features of Kawasaki disease that we can go with the mnemonic of crash. So first is conjunctivitis with limbus sparing. We can see in this picture in which the red eyes, which means red eyes with a white margin around the iris. Okay, next is rash that might extend across multiple parts of the bodies, which starts polymorphous, and after a few period of time, it may starts to desquamates or flakes off. The third clinical features of Kawasaki disease is adenopathy, particularly we are concerning about the cervical lymphadenopathy, lymph node enlargement. The fourth one is strawberry tongue, which when the top layer of the tongue slough off, it gives the tongue a very red strawberry-like appearance, and their mouth and throat may also look very red, and the lips may look very dry and cracked. Last but not least, the principal features of Kawasaki disease is the hands and the feet swollen and may develop rash. So here also I included some of the helpful signs in making the diagnosis. However, these 5 principal features remains the main part. Okay. Next, I'll be explaining briefly about the clinical stages of Kawasaki disease, which can be divided into 3 stages. Stage 1 is acute febrile stage, stage 2 subacute stage, and stage 3 convalescent phase. In which in the stage 1, it begins with the abrupt onset of fever that lasts approximately 7 to 14 days. And the fever is typically high spiking and remittent and does not resolve with antipyretic. In stage 2 of Kawasaki disease, it begins when the fevers have abated and it continues until week 4 to 6. And the hallmarks of this stage we can see is the disformation of the digits, thrombocytosis, and also development of coronary artery abnormalities such as aneurysm. In the stage 3 of Kawasaki disease is convalescence phase, which is marked by complete resolution of clinical signs of illness, usually within 3 months of presentation. And in this stage, it begins with the return of the baseline of acute phase reactant and other laboratory abnormalities. And some authors may add the chronic phase, which this stage is of clinical importance only in patients who have developed cardiac complications. So now how to diagnose the Kawasaki disease. So remember the 5 principal clinical features earlier that I showed, the pneumonic with rash, or you can actually refer to this table. So in order to diagnose the Kawasaki disease, we can actually divide it into 2 main diagnosis, which is complete KD and incomplete KD. So in complete KD, the diagnosis requires fever of at least 5 days duration, along with 4 or 5 of the principal clinical features. Meanwhile, in incomplete KD, it is diagnosed when the patient presents with fever for 5 days or longer, along with 2 or 3 of the principal clinical features, but with the help of laboratory findings that are suggestive of the disease or any echocardiographic abnormalities. In the first protocol, there are also include atypical KD, in which the Kawasaki disease comes out with an atypical presentation, for example, renal impairment, which is generally not seen in Kawasaki disease. However, we are focusing in those complete KD and incomplete KD. Okay. So next, we go to the investigation. So basically, there is no diagnostic test to diagnose the Kawasaki disease, but it may act as clues, especially in diagnosing the incomplete Kawasaki disease. And for the diagnosis is usually made on the clinical findings alone. So what are the investigation or parameters we need to look at to actually help us in diagnose the Kawasaki disease? So first is the full blood count. We might expect to see anemia, particularly normochromic normocytic anemia, leukocytosis with neutrophilia and immature forms of white blood cells, and also thrombocytosis, especially after week 1 of onset of symptom. Next is erythrocyte sedimentation rate and C-reactive protein. We expect it to be elevated because this may act as clues to the inflammation going on. Next is serum albumin. We might expect to see hypoalbuminemia, especially when there is a damage in endothelial cells. There may be vascular leakage that leads to the low albumin in the serum. Next is ALT. We expect it to be raised because most patients with the Kawasaki disease comes with the raised ALT. Next is urinalysis. We might expect to see the patient to have steroid pyuria, which is increase in white blood cells without evidence of bacterial infection in urine. Next is chest X-ray or ECG or echocardiogram. It is important to evaluate for the complication of KD, especially associated to the cardiac complication like aneurysm and so on. Next is complication. So basically, as has been explained in the pathogenesis part, so the Kawasaki disease might come up with a complication of coronary artery aneurysm, myocardial infarction, especially when there is blockage to the blood flow to the heart, and the rupture of the coronary artery with hemopericardium. This is especially in case of large aneurysm, but however, this is rare to occur. That's is myocarditis, inflammation of the myocardium. Acute thrombosis, when there is exposure of the collagen and the tissue factor, may cause the blood coagulate and to form the blood clots and so on. Next is valvulitis, usually mitral, but however, this only occurs in 1% of the patient. Ray syndrome. Why Ray syndrome? Because it is associated to the aspirin that are used as the management of Kawasaki disease. However, it is not uncommon to see Ray syndrome in Kawasaki disease. Last but not least of the complication is sudden death. That might be because of the MI or another complication. So next is the principles of management, in which the goals of the treatment can be divided either in the acute phase or as the long-term therapy. So in the goals of treatment in the acute phase is to rapidly reduce the inflammation of the coronary arteries and to minimize the incidence and progression of coronary artery aneurysm and to prevent any arterial thrombosis. Meanwhile, long-term therapy in individuals who develop coronary artery aneurysm is aimed at preventing myocardial ischemia or infarction. So the treatment of the Kawasaki disease can be according to the stage. In the acute stage, or we call this as the primary treatment, we give the intravenous immunoglobulin 2 grams per kilogram over 10 to 12 hours, and also we give aspirin 80 to 100 milligram per kilogram per day divided every 6 hours orally until patient is afebrile for at least 48 hours. In the convalescent stage, as the maintenance stage, we give the aspirin 3 to 5 milligram per kilogram once daily orally until 6 to 8 weeks after illness onset, with the condition of normal coronary finding throughout the course. But if the patient have coronary abnormalities, the long-term therapy would include to give the aspirin and also clopidogrel, which is the antiplatelet, and some experts will add warfarin or low molecular weight heparin for those patients at particularly high risk of thrombosis. In the case of acute coronary thrombosis, prompt treatment with fibrinolytic therapy with tissue plasminogen activator or other thrombolytic agent under supervision of a pediatric cardiologist. So one more, if the Kawasaki disease not responding to the primary treatment, it is defined as a persistent or recrudescent fever more than 36 hours after completion of initial dose of IV immunoglobulin. So in this patient, we repeat another treatment of IV immunoglobulin, 2 grams per kilogram infusion over 10 to 12 hours. I think, so this is my references.
All right, okay. Continue the next one.
So, Bismillahirrahmanirrahim. So my name is Faiz On, and I'm going to present tonight about scarlet fever and rheumatic fever. So this is the outline. So we are going to talk about the overview, the clinical finding, the investigation, the complication, also the management. So by definition, what is scarlet fever? So scarlet fever is an upper respiratory tract infection associated with rash and is caused by infection with pyretic exotoxin produced by group A Streptococcus individual who do not have antitoxin antibody. So basically, what is it is a upper respiratory tract infection with rash, and the causative organism is group A Streptococcus bacteria. Meanwhile, what is rheumatic fever? So rheumatic fever is an inflammatory disease of childhood resulting from untreated Streptococcus pyogenes or group A Streptococcus pharyngeal infection. So basically, rheumatic fever is the sequelae of scarlet fever. It's the complication of scarlet fever itself. Okay, and the common age group children that will have this type of disease around 5 years to 15 years of ages. And also, both male and female are equally susceptible to have this sort of diseases, regardless of gender. So how a scarlet fever occurs is basically the endotoxin from the bacteria will circulate through our circulation, and hence it's caused the production of local inflammatory mediators and produce immune response, and also cause the dilatation of blood vessel. And these responses, hence the formation of rash, scarlet colored rash. Okay. Meanwhile, rheumatic fever is due to molecular mimicry. One of the virulent factor for group A Streptococcus bacteria is that the M protein, the structure is more or less the same with the host. So the phagocyte is unable to distinguish between the microbe and host, and hence that is why inflammation still persists beyond acute infection due to the molecular mimicry of the bacteria. So this is the clinical manifestation. For scarlet fever, we know that is upper respiratory tract infection, and the most common site is the pharynx. So the clinical manifestation is the fever, sore throat, headache, nausea, vomiting, and also the clinical sign for it to cause scarlet is the presence of rash. So this is what you need to know, but you need to know the characteristic of the rash itself. So the rash will initially begin around the neck and will go straight throughout to the trunk extremities. And the most strengthened is in the crease of the elbow, axilla, and groin. And you need to know that the rash will begin to fade after 3 to 4 days and followed by desquamization. So desquamization occurs initially basically occurs on the face and continue on the fingernail and the palm of the torso. So the characteristic of the rash you need to know is that it's a diffuse, a finely popular erythematous. So when you touch the rash, you will feel like it has a practice of sandpaper, a coarse sandpaper. So it also blanches on pressure. So when you pinch it, it becomes white, blanches. That is the scarlet fever. For the rheumatic fever, so you need to know is that the patient can have polyarthritis, pancreatitis. Pancreatitis means that it's inflammation at the pericardium, at the myocardium, at the endocardium. But the most common site that we need to take note is about the endocardium, which it can affect the valvulitis, especially the mitral. The next clinical manifestation is syndrome chorea. So chorea is a form of dyskinesia. So what it do is that it's involuntary, irregular movement of the upper lip and also the face. So the patient cannot control the movement of his upper limb and also his facial expression. So next is erythema marginatum. So erythema marginatum based on its name is erythema, which means red, marginatum, margin. So you can see the margin. So basically, so you know that this is the erythema marginatum. So the center is pale, meanwhile the outside is red. So you can find it's like an island here. Outside is the red and the central is pale. The next manifestation is subcutaneous nodule, and the nodule is painless. This is the photo of clinical finding you can find scarlet fever. So here you can see the strawberry tongue. So usually can be white strawberry tongue. After 3 or 4 days, because this conversation occurs, it becomes bright light, just like Kawasaki. Then there's also the presence of pastilla line, a petechiae that you can usually find at the groin and also at the elbow. And also circumoral pallor, which is the area around the mouth become pale. And next, the rash, which you need to know the characteristic of the rash. the Cossen paper finding, the blanches, and also the suppurative tonsillitis. This is the diagnostic criteria for both the scarlet fever and also the rheumatic fever. This is you need to know about the CENTO score for acute pharyngitis. So what you need the parameters for this diagnostic criteria is for the scarlet fever. First of all, you need to know that the the age plays a role in diagnosing the patient whether he has group A streptococcus infection or not. Because the most common age is around 5 to 15 years old. So if the patient is around 3 to 14 years old, you need to add +1 in it. If the tonsil exudated or swelling, +1. And also the presence of tender or swollen anterior cervical lymph node, +1. And also the temperature is more than 38 degrees Celsius, +1. And also the cough. You need to know about the cough. If the patient has no presence of cough, so it's possible that the patient have group A streptococcus infection. So you add it up. So if the score is around 4 or 5, there is 56% that this patient have group A streptococcus infection. Hence, we need to go for throat culture or rapid strain test, and also give antibiotic if possible, if positive. That is for the scarlet fever. Next is for rheumatic fever, which is we need to know the Jones criteria. For the Jones criteria, it is divided into major and minor. For the major, you need to know if the patient have carditis, polyarthritis, syndehanchoria, erythema marginatum, or subcutaneous nodule. For the minor, the parameters are fever is more than 38 degrees Celsius, raised ESR or CRP, and prolonged PR interval in ECG finding. So to diagnose patient to have a rheumatic fever, the patient must have either 2 major criteria or 1 major plus 2 minor with evidence of preceding group A streptococcus infection. This is the you need to know the criteria for you to diagnose patient with rheumatic fever. Next is the lab investigation. So for the scarlet fever, what you can order is for food blood count. So maybe you can find leukocytosis, inflammatory marker. It is a raised CRP, raised ESR. You also need to know for renal profile and UFEME because one of the complications for scarlet fever is acute glomerulonephritis. And also for the diagnostic investigation, you can also order for throat swab culture, and you need to take note that it's a gold standard for you to diagnose someone with group A streptococcus infection. For the rheumatic fever, because we know that the causative organism is the same as scarlet fever, and it's a complication of scarlet fever. So it's more or less the same as scarlet fever. So you need to order full blood count, inflammatory marker. What you need to take note if for patient who have rheumatic fever, take note, monitor the complication. So you need for echocardiogram because the common complication for patient with rheumatic fever in children is rheumatic heart disease. So you can order for echocardiogram, chest X-ray, ECG. And the throat swab is you need to know the causative organism. Next, the complication for scarlet fever. We know that the endotoxin can spread throughout the blood circulation, so it can affect multi-organ in our body. So hence, it can cause pneumonia, otitis media, rheumatic fever, acute glomerulonephritis, myocarditis, toxic shock syndrome, meningitis. And also, next is for the rheumatic fever. What we need to take note of is the complication is the rheumatic heart disease. Because in children, for children to have acquired heart failure is very rare. Because most of the time, children has come with congenital heart failure. And one of the common acquired heart failure is caused due to this infective carditis due to rheumatic heart disease. And this is the management you need to take note of. For the scarlet fever, you need to give basically to eradicate the bacteria itself. So give antibiotic treatment, which is you need to give penicillin. And if the patient is allergic to penicillin, we can give cephalosporin, macrolide. And so you can also give supportive care for the patient, give adequate rest, fluid intake, and also give paracetamol, acetaminophen. For the rheumatic fever, again, it's due to the complication of the scarlet fever. So what you need to do is to eradicate the bacteria. So you need to eradicate the group Streptococcus carriage. So give antibiotic treatment. And also you need also to treat for the complication of the rheumatic fever, which is for the arthritis, we can give aspirin, naproxen, ibuprofen. However, because we know that aspirin is the side effect in children is very, can cause Raynaud syndrome, right? So it's rare to give aspirin, so we can give naproxen. Next is rheumatic heart disease or carditis. So what you need to treat is patient, the patient as you manage the patient with general heart failure in children. So it's a different topic by itself. So basically, what you need to do is give diuretic, angiotensin, receptor blocker, beta blocker, and digoxin. And so next is for the patient who have Salehin chorea. So for this patient who have got the Salehin chorea, the symptom resolve normally by itself, because between in about 6 weeks to 6 months, it will resolve by itself. However, if there's symptoms still persist, you can give a dopamine to receptor blocking agent. So this is my reference. I think that is all for me.
All right. Okay. I think we'll take a short 5 minutes break. In the meantime, if any question, you just think about it and we discuss the question at the end. We'll take 5 minutes break. Okay, guys, can we continue?
All right. Okay. Assalamualaikum warahmatullahi wabarakatuh. So, my name is Ratna binti Ruzairi, and I represent about systemic lupus erythematosus, or known as SLE. So first of all, we need to know what is SLE. SLE is a chronic autoimmune disease characterized by multi-system inflammation and presence of circulating autoantibodies directed against self-antigen. So in short, SLE is autoimmune disease, and as the name suggests, systemic. So it will affect multi-system organs such as skin, kidney, joint, and also central nervous system. So in pediatrics, research showed that female have more prone to get SLE compared to male children, with the ratio of 5:1. And usually SLE is diagnosed during the children more than 8 years old, and rarely during the children is less than 5 years old. As the comparison between children and adult, children has less prevalence in SLE compared to the adult. However, they will have more severe disease as compared to the adult. So as you can see, this is example of mucocutaneous manifestation of SLE in pediatrics. The first one is malar rash. Malar rash, also known as butterfly rash, and the next one is vasculitic rash on the toes. And at the bottom, there is oral ulcer. And then at the last picture is discoid rash. So how to differentiate between malar rash and discoid rash? First, we need to know the definition. For malar rash, it is defined as a fixed rate, either flat or raised over the bridge of the nose, and usually it involves the cheeks, and it usually spare the nasolabial fold. And for discoid rash, it is defined as dark or red patches of inflammation or scarring. I'll talking about pathogenesis. So for the pathogenesis, first you need to know that children with SLE, their skin are more prone to cause damage when they are exposed to UV light. So when they are exposed to UV light, the cell will lead to necrosis or apoptosis and lead to the release of the cell contents, including the nucleic acid antigen. So in normal physiology, there will be mechanism of clearing of the cell debris. However, when in children with SLE, the apoptosis will keep increasing. So the mechanism of clearing of the cell debris cannot compensate the clearing of the cell release content. So this will lead to the prolonged exposure of the antigen to the bloodstream, and they will be recognized by immune cell, lead to the production of autoantibodies by B cells. And these circulating autoantibodies will form immune complex, and then they will activate complement and also pro-inflammatory cascade, and they will deposit it at the various kind of tissues such as kidney and joints and lead to damage. Not only B cells involved in this pathogenesis, T cells also actually involved in pathogenesis, as T cell will increase the number of memory T cells and it will suppress the function of regulatory T cells. So what is regulatory T cells? Regulatory T cells are the type of T cells that will suppress the number of immune cells. So when T cells suppress the function of these T regulatory T cells, it will lead to the increasing number of immune cells. And this is the clinical features. So actually SLE can affect any organs, but and it also is a progression disease. So means that even when the children have been diagnosed with SLE many years, there can still be new manifestation. And the most common manifestation in children are hematologic abnormalities and also mucocutaneous abnormalities. For hematologic abnormalities, there will be thrombocytopenia, leukopenia, lymphopenia, and also anemia. And for mucocutaneous abnormalities, they accounted 70% in children of SLE, as we have seen in the previous slide before, such as malar rash, discoid rash, oral ulcer, and vasculitis rash on the toes. And the next common one is musculoskeletal abnormalities. There are 64% of the children in SLE have this. The most common one is arthritis and arthralgia. And these arthritis and arthralgia are not painful. And the next one is fever and also fatigue. 58% of children in SLE manifest this symptom. And please bear in mind that fever in SLE usually low-grade fever. However, they may also have high-grade fever. So for renal, the renal symptom usually asymptomatic unless there will be, if the autoantibodies have deposited in kidney, there will be proteinuria, hematuria, means that the kidney already impaired. And there is also manifestation called lupus nephritis. Based on what I read, lupus nephritis in children is not common. It is more common in adolescent type of SLE. And the next one for cardiovascular, the most common manifestation is pericarditis. And for neurologic, peripheral neuropathy, chorea, and also cranial nerve palsies are rare manifestation. And for pulmonary, pruritus is common. And children we present with type of chest pain defined as stabbing or sharp that will worsen during inhalation. And pulmonary hypertension is rare. And the next others you can read it. So the next one is diagnostic criteria for SLE. So we can diagnose SLE in children based on 2019 European League Against Rheumatism (EULA) or American College of Rheumatology ACR. So based on this criteria, there's a few conditions need to meet in order to diagnose the children with SLE. First of all, must meet entry criterion. For entry criterion, it is positive anti-nuclear antibody test and a test. And however, if a patient have negative test of ANA and a test came out negative, we cannot diagnose the patient with SLE. The next one is meet at least one clinical criterion, either hematologic, mucocutaneous, or others. And the last one, the total score between clinical domains and also immunology domains must meet more than 10. So if we meet these three conditions, then we can diagnose the patient with SLE. Other criteria diagnosis that can be used are American College of Rheumatology 1997, and also Systemic Lupus International Collaborating Clinic Criteria, SLICC. Now we move to lab investigation. So for lab investigation, we'll proceed with full blood count. So as I mentioned before, it is the most common manifestation in children with SLE. Children will have anemia, leukopenia, thrombocytopenia, and also lymphopenia. The next one is erythrocyte sedimentation rate. It usually elevated in active disease. And this blood test is actually a type of blood test where we will see the time taken for erythrocyte to settle down at the bottom of test tube, and usually the time taken to settle down is relatively slow. So when the time taken is higher than normal rate, so it will indicate inflammation. And the next one is C-reactive protein test. It is normal unless the SLE is complicated with infection. The next one is serum total hemolytic components, CH50, serum C3, and serum C4. It will decrease and improve with treatment. Why it is decreased? Because as I mentioned before in pathogenesis, there will be activation of complement system. So this C3, C4 will convert into C3A, C4A, and others. The next one is renal profile. So for renal profile, the children will have proteinuria, hematuria, increased creatinine, and also decreased GFR. And for lupus nephritis, to diagnose it, we need to do renal biopsy for the additional investigation. And the next one is the presence of autoantibodies. Actually, there are a lot of autoantibodies tests in SLE patient. The first one is anti-nuclear antibody, or known as NI antibody. This type of antibody is like all children who have SLE will have positive NA test, but it is not specific for SLE because this NA test antibody also may be positive in HIV patient. The next one is anti-Smith antibody. It is specific for SLE but not correlate with the disease. And the next one is anti-double-stranded DNA antibody. This is positive investigation. It may come out positive, more specific, and correlate with disease, especially in nephritis. Additional investigation we can do is chest X-ray, renal biopsy, vitamin D to look for osteoporosis. And then the next one is principal management. So the management in SLE is varied, depends on the types of organ involved. However, the aim is first to slow down the progression of SLE. Second one is to maintain health and function, and third one is to reduce the side effect of the treatment. So we can divide the management into general and also specific. For general, as we know that patients with SLE are more to have damage when they are exposed to sunlight. So it's important to have some protection such as sunblock, avoid activities under the sun, and wear protective clothes when they are exposed to the sunlight. The next one is adequate nutrition, such as give a lot of calcium and also vitamin D, because they might manifest osteoporosis. And then the next one is immunization. Immunization, particularly pneumococcal and also influenza. This is because children in SLE, they are more prone to get infection. And for a specific one, we have corticosteroid, immunosuppressive, biologic agents, hydroxychloroquine, and others. So for corticosteroid, it is required by all children, even in absence of major organ involvement. The types of corticosteroid usually is prednisolone and also methylprednisolone. So prednisolone is given orally and methylprednisolone is given IV. And tapering of steroid dose should be done once the disease is controlled. And generally, the higher the dose, the faster the taper. And during the active phase, we need to divide the dose of corticosteroid to minimize the side effect. The next one is immunosuppressive agent. Immunosuppressive agent needs to be given as early after the diagnosis of SLE. And the type of immunosuppressive agent depends on the organ involvement. The most common type of immunosuppressive that be given to children with SLE are azathioprine, because it can be given when the patient have hematologic manifestation, dermatologic, serositis, vasculitis, and lupus nephritis. The next one is intravenous cyclophosphamide. This will be given when there is a major organ involvement like renal, cerebral, cardiac, and pulmonary. The next one is methotrexate, when there is arthritis, myositis, and also skin disease. And the last one is cyclosporine, when there is involvement of nephritis or renal. And the next one is biologic agents. We have two types of biologic agents, that is rituximab and belimumab. So this rituximab is actually chimeric anti-CD20 monoclonal antibody, and it will suppress the B lymphocyte, as the B lymphocyte play the vital role in pathogenesis of SLE. So the next one is belimumab. So belimumab is immunoglobulin G1 lambda monoclonal antibody. It works by block B cell activating factor, that is cytokine, that important for B cell differentiation and also survival. The next one is hydroxychloroquine. Hydroxychloroquine, such as antimalarial, is given to reduce the flash and also antibodies protection. But we need to give this hydroxychloroquine with caution, because it can have a lot of side effect and toxicity. And others, such as NSAIDs to reduce the pain, and also antihypertensive, and also is inhibitor if the patient is have pulmonary hypertension or any hypertension disease. And then the next one is follow-up management. For follow-up management, first of all, we need to look for evidence of active disease. The next one is to look for complication. And the next one is compliance to regimens. And the last one is to perform lab investigation to adjust the treatment. As I mentioned before, particularly in corticosteroid, we need to taper the dose when the disease is controlled. And the last one is complication. So the complication of SLE are medication toxicity, infection, and macrophage activation syndrome. So first of all, for medication toxicity, usually it correlates with long-term use of corticosteroid. And the common one to see in SLE patient are cataracts, avascular necrosis, and also osteoporosis. And ocular toxicity is the greatest concern with hydroxychloroquine therapy. The next one is infection. As I mentioned before, SLE patient is more prone to get infection due to the decreased white blood cell in their body. So it's important to give them immunization. Additional info, when there is active phase or during active phase of SLE, we cannot give live vaccination to the patient because it can induce more flares. And the next one is macrophage activation syndrome. This is a rare complication. However, it's a life-threatening complication. It is caused by activation of T cells and macrophage, resulting in massive release of pro-inflammatory cytokines, such as interleukin 1, interferon, and others. And clinical manifestation include persistent high fever, pancytopenia, hepatosplenomegaly, and also hepatic dysfunction. So I guess that's all. This is my references.
All right, continue with presentation.
Okay, Assalamualaikum everyone. I hope you can hear me.
Yes, we can.
Okay, thank you. Okay, so my name is Muhammad Fawaz Naim bin Kamarizan, metric number 1811253, and I'm going to be presenting about juvenile idiopathic arthritis. Okay, so based on the name itself, you can kind of figure out what the disease is about. So juvenile means a young person, idiopathic means the disease occurs spontaneously without a cause, and arthritis is inflammation of the joints. So it roughly means the inflammation of joints that occur in children without a known cause. Okay. But the proper definition of JIA is persistent joint swelling of more than 6 weeks in duration, presenting before 16 years of age in the absence of infection or any other defined cause. So juvenile idiopathic arthritis is the most common rheumatic disease in children and one of the more common chronic illnesses of childhood, with a prevalence of approximately 1 in every 1,000 children. To diagnose the disease, we need to exclude all other differential diagnoses of arthritis, such as other rheumatic diseases or infections. The causes are unclear, but can be associated with alterations in both humoral and cell-mediated immunity. So as you can see from the picture, the first picture shows polyarticular GIA, which is one of subtype of GIA, and shows swelling of the wrist, metacarpal, and interphalangeal joints. And the second picture shows a stunted kid with a genu valgum, which is a knock knees. Okay, moving on to the classification of GIA, there are 7 different subtypes. Okay, so first we need to differentiate between oligoarthritis and polyarthritis. Oligoarthritis is when the arthritis involves 4 or less joints, while polyarthritis is when the arthritis involves 5 or more joints. Oligoarthritis is further then divided into 2. One is persistent and the other one is extended. Those in whom the disease never develops more than 4 joints are regarded as having persistent oligoarticular, while evolution of the disease in more than 4 joints after 6 months changes the classification to extended oligoarthritis. So in oligoarthritis, the age onset is about 1 to 6 years old, and it affects female 5 times more likely than male. The articular pattern, just like I said, it involves less than 4 joints. Most common will be knee, ankle, and wrist. Extra-articular features will include chronic enterouveitis and leg-lung discrepancy. So next is polyarthritis. Polyarthritis is also divided into 2. One is rheumatoid factor negative, and the other one is rheumatoid factor positive. So in rheumatoid factor negative polyarthritis, the age onset is 1 to 6 years old. With female sometimes more likely as well. It involves symmetrical large and small joint arthritis, often with marked finger involvement. Extra-articular features include low-grade fever, uveitis, and also reduction of growth rate. Rheumatoid factor positive polyarthritis resembles characteristic symmetric presentation of adult rheumatoid arthritis. If your left hand have arthritis, the other hand will also have arthritis. If your left ankle have arthritis, the other ankle also have arthritis. So next would be systemic juvenile idiopathic arthritis. It is characterized by arthritis, fever, rash, and prominent visceral involvement such as hepatosplenomegaly, lymphadenopathy, and also pericarditis. The fever has a characteristic feature, which is spiking temperatures to more than 39 degrees Celsius, which occur on a daily or twice daily basis for at least 2 weeks, with a rapid return to normal or subnormal temperature. And the fever is frequently accompanied by a characteristic salmon pink macular rash. Age onset is 1 to 10 years old and affects equally between male and female. So next is psoriatic arthritis. It affects patient 1 to 16 years old and also affect equally between male and female. Psoriatic arthritis is a form of arthritis that affects some people who have psoriasis. Psoriasis is a skin disorder that causes skin cells to multiply up to 10 times faster than normal, which makes the skin build up into bumpy red patches which cover with white scales. So, and the last one is enthesitis-related arthritis. It occurs in patients 6 to 16 years old and affects male 4 times more common than female. So enthesitis-related arthritis, other than having arthritis, the patient also have enthesitis, which is the inflammation of the entheses. The entheses is a connective tissue where tendons or ligaments attach to the bone. And HLA-B27 is strongly associated with enthesitis-related arthritis. From the patient history, there are a few features that can indicate that the patient's having juvenile idiopathic arthritis. First is gelling. Gelling is the stiffness of the joints after periods of rest, such as long car journeys. Morning joint stiffness and pain can also occur in a patient with juvenile idiopathic arthritis. In young children, they also may present with intermittent limp or changes in behavior or mood. And also valgus deformity is a condition in which the bone segment distal to a joint is angled outward, which means it's angled laterally away from the body's midline. And the most common is valgus knee, which is the picture of the earlier girl in the introduction slide. This one. Okay. Moving on to clinical findings. arthritis is a must. What is arthritis? Arthritis is defined by intra-articular swelling or the presence of two or more of the following signs, which are limitation in range of motion, tenderness or pain on motion, and warmth. In rheumatoid factor positive individuals, rheumatoid nodules may be presented. Although unusual, rheumatoid nodules are associated with a more severe cause, thus needing more aggressive therapy. And just like I said earlier, systemic juvenile idiopathic arthritis can be presented with arthritis, fever, rash, hepatosplenomegaly, lymphadenopathy, and pericarditis. Okay, juvenile idiopathic arthritis, the diagnosis is essentially clinical, thus lab investigations are only supportive, which means no lab test or any combination of tests can confirm the diagnosis of GIA. So we can do full blood count and peripheral blood film, which can exclude leukemia. And we can also check for elevated white blood cell or platelet count and also microcytic anemia, which means anemia of chronic disease. We can also check for erythrocyte sedimentation rate or C-reactive protein, which usually is elevated in inflammation. X-ray of affected joint is also done to see soft tissue swelling, periarticular osteopenia, and also periosteal new bone formation, which causes the arthritis in the patient. Next, we can check for anti-nuclear antibody, which increase the risk of chronic enterouveitis in patients. Rheumatoid factor can also means it's a marker of a more aggressive disease, thus needing more aggressive therapy, and others to exclude other diseases such as anti-streptolysin O titer, ferritin, or check for complement levels. Moving on to the complications of GIA, there are four main complications. The first one, which is chronic enterouveitis. This is a common complication, but usually asymptomatic in the early stages, and if not detected and treated, can lead to severe visual impairment due to cataract and glaucoma. So in patients, they need to get regular ophthalmological screening using a slit lamp, especially for children with oligoarticular disease and those who have positive ANA, anti-nuclear antibody. So the next complication is growth failure. Growth failure can occur due to anorexia, chronic disease, or even systemic corticosteroid therapy. It can also be localized overgrowth, such as leg length discrepancy due to prolonged active knee synovitis, and also undergrowth due to premature fusion of epiphysis. But growth problems are largely preventable in the early diagnosis and treatment. So next will be flexion contracture of joints. A flexion contracture is a bent flex joint that cannot be straightened actively or passively. This occurs when the joint is held in the most comfortable position, thereby minimizing intra-articular pressure. And the last complication will be osteoporosis. Osteoporosis can caused by many etiologies such as diet or even systemic corticosteroids. We can reduce the risk by giving dietary supplements of calcium and vitamin D, active lifestyle, and also minimizing corticosteroid use. Okay, so next is principle of management. The aim of management in patients with GIA is to induce remission as soon as possible, prevent joint damage, control inflammation, and prevent joint deformities. There are two terms that we need to understand. First are immunomodulator, and the second one is biologic agents. Immunomodulator is the treatment of disease by activating or suppressing the immune system, which means you modulate the immune system. While biologic agents is a substance that is made from a living organism or its product, and is used in the prevention, diagnosis, or treatment of cancer and other diseases, which includes antibodies, interleukins, and vaccines. So now is the pharmacological treatment. We can give NSAIDs, analgesics such as naproxen and ibuprofen. It does not modify the disease, but it can help relieve symptoms during flares. It can also show improvement in inflammation and pain. But those who have no or partial response after 4 to 6 weeks of treatment with NSAIDs, or those who have functional limitations such as joint contracture, can get some benefit from injection of intra-articular corticosteroids. such as triamnicolone. So triamnicolone is used for intra-articular injection. It is also the first-line treatment in oligoarticular GIA. It can also be used as a bridging agent when starting methotrexate in polyarticular disease. So next will be immunomodulator, or DMARDs is disease-modifying anti-rheumatic drugs. The examples are methotrexate and sulfasalazine. These drugs are second-line drug treatment given to children with persistent or severe arthritis. Early use can also reduce joint damage, but it's less effective in systemic features of GIA. If the patient does not get better even after giving methotrexate, we need to give biologic agents such as TNF-alpha antagonist, IL-1 inhibitor, or even IL-6 receptor antagonist. So these agents can inhibit pro-inflammatory cytokines, and it's useful in severe disease resistant to methotrexate. The last one will be non-pharmacological management of patients with GIA. So first will be physiotherapy. So physiotherapy aims to avoid prolonged immobilization, and it can also help to strengthen muscle and improve the range of movement. And in patients undergo physiotherapy, they can also improve in balance and cardiovascular fitness. Occupational therapy, we can do splinting. Splint is a device that maintains your joint position to keep it in place, and we can do splinting when necessary to reduce the pain and preserve the joint alignment. Next will be referred to ophthalmologist. So all patients must be referred to the ophthalmologist for uveitis screening, as uveitis sometimes can be asymptomatic and have regular follow-up even if initial screening is normal. Other management include ensure well-balanced diet and high calcium intake, and encourage regular exercise and participation in sports and physical education. So these are my references, and that's all. Thank you.
Okay. Okay. Excellent presentation, everyone. Okay. Before we go to the Q&A session, okay. Just want to touch on GIA first. You should know the generalized classification. Good for you to know in detail what is it, and what is the classification which has been given by your colleague. It is called ILA classification. All right, so you can find out later. And with regard of SLE, okay, the scoring in clinical practice, yes, should this will be done in a rheumatology clinic, but you in exam for exam purpose, you must know the components of the score. I mean, I doubt anyone can remember the score 1, 2, 3, 4, right? But ultimately is what are the component of that make the diagnosis of SLE. So what are disc lupus, all right? So component what cell, lab result. These are actually you must be able to know this component of the SLE. Rheumatic fever, scarlet fever is quite straightforward, but what do you call this? The Jones criteria you must remember. Okay. What else? HSP is again straightforward, not much of an issue. Then what's the other one? What other topic we discussed just now?
Kawasaki.
Yeah, Kawasaki. Kawasaki, the criteria you must know, right? You must know what's the criteria. Okay. All right. Any question in relation to all the presentation? I think quite straightforward. Good. I think you follow the guideline. This is what you actually you can go through the slide. I think it's more than enough for you. All right. It is quite extensive, and all the question either written or even in the clinical exam, that what has been outlined by the presenters. Okay. All right. Okay. If no question, then again we can end with tasbih kifarah for us. All right, and then group the leader, please what do you call this? Email me the presentation later. Okay. All right. Assalamualaikum warahmatullah.
Thank you, Doctor.
Waalaikumsalam. Thank you.
Thank you, Doctor.
Thank you, Doctor.